Next up, ladies and gentlemen, it is my pleasure to welcome you to this next segment and welcome my panelists for the panel discussion who are joining us today from Heidelberg, from Toronto and Montreal to discuss the AI revolution in surgical care and if it is in fact a paradigm shift for surgery. Plus, we'll find out about the latest developments and milestones that our guests are working on at the moment. So here we go. Please welcome from Heidelberg in beautiful Baden-Württemberg, Dr. Jan Lahmann. Jan is the Vice Chair at the Department of Anesthesiology at the Universitätsklinikum Heidelberg. He is the speaker for an innovative project named COMED, which he will be talking about in just a few moments. I'd like to welcome from Montreal in the Canadian province of Quebec. Please welcome Dr. Rolando Del Maestro. Rolando is a William Findle Professor Emeritus in Neuro-Oncology at the aforementioned McGill University. He's the director of the Neurosurgical Simulation Research Center, as well as healthcare entrepreneur, physician, philanthropist, and also Leonardo da Vinci expert. And last but not least, joining us from Toronto in Ontario, Canada, please welcome Dr. Muhammad Mamdani. He's the director at the Timirti Center for Artificial Intelligence, Research and Education in Medicine, which is called, in short, TCARM at the University of Toronto. There's also very many facts about him. I'll just pick out one. He was named one of Canada's top 40 under 40, but that was just a few years ago. So thank you very much, gentlemen, for joining us today and sharing with us what you're working on, what's keeping you busy, what developments you're most excited about. And of course, we have questions prepared for you, but please, if you feel you'd like to ask each other questions, don't hesitate to do so. And dear viewers, if you have questions for our panelists, which I'm sure you do, we have a Q&A session at the end of the panel discussion. If you have questions, write them in the chat. To make it easier for us, direct the question at whoever the question is supposed to be for, so we can easily identify them. And with that, dear audience members, to give you a little bit of a better overview of our panelists, I could just briefly introduce you. So, dear panelists, I'd like to give you the opportunity now in a, let's say, short opening statement to share with our audience what milestones have you achieved in the past and which ones are you aiming for in the next few years. So take a bit of time to answer that question. And Muhammad, I'd like to start with you.
Sure. Hi, everyone. You can hear me okay?
Yes.
Fantastic. It's a pleasure to be here. Really appreciate the time. I come from a center called the Unity Health Toronto, which is a composition of 3 hospitals, St. Joseph's, St. Michael's, and Providence Healthcare. We have a dedicated program in AI. We're, I think, the only hospital in the country where we've declared artificial intelligence as one of our core strategic pillars. So we have 8 strategic pillars, and our board has pushed us to say, all right, what are the 3 top ones you really want to focus on? And AI is actually one of them. So it's from the top all the way down. AI is a huge priority for us. What that means is that we've actually put in some resources, and I have a dedicated team of about 30 data scientists. And our job is to develop and deploy AI solutions into clinical practice. So in our hospital, we have well over 40. Now, I think it's closer to 50 AI solutions that are running live as we speak. Some examples include optimization algorithms to help our nurses assign nurses to the different zones in the emergency department. We've seen at least an 80% reduction in human effort, going from over 2 hours a day to under 15 minutes, error rates going from 21% to under 5%, seeing a lot of efficiency gains there, all the way to clinical prediction algorithms, which have implications for surgery. For example, we have something called ChartWatch. It's been running for over 2 years now, and it's an AI algorithm. It's been trained on over 20,000 patients worth of data. What it does is every hour it runs, and every hour on the hour, it predicts in the next 48 hours if this patient is going to die or go to the ICU. And it categorizes patients as low, medium, and high risk. As soon as it reaches a high-risk threshold, it's automated to page the medical team. And our protocol is the medical team then has to come and see the patient within 2 hours of being paged. And then it has all sorts of care pathways, like increased monitoring to every 4 hours, look for signs of sepsis, think about initiating antibiotics. We deployed this in our general internal medicine unit about 2 years ago, and we've seen at least a 26% reduction in mortality. So we believe these things are saving lives. We've recently deployed this in our surgical unit, so post-op, to monitor our patients because our physicians are not there all the time, every second of the day. And our preliminary data are suggesting a similar 27% reduction in mortality. So we find these algorithms will be able to help on post-surgical management. But what we're also doing now is we're getting more into the surgical space. We're bringing in these boxes that are actually going to be taking out data from our monitors in the ICU, our ventilators as well, in real time. So what we envision are these technologies that will be pulling in data second by second, being analyzed by AI algorithms, and actually helping our surgeons in the OR ahead of time, identifying, in the next 5 to 10 minutes, you're going to see a major drop in blood pressure, or you're going to see some sort of trouble here. So maybe just have a heads up. There are also other technologies at Toronto General Hospital, for example, that are using real-time surgical guidance. So, for example, as you're operating, Dr. Amin Madani is actually leading this at the Toronto General, where it will actually highlight green zones on where incisions can be made and red zones where, if you make them, they may have a higher rate of post-surgical complications. So I know I don't have that much time, so I just want to summarize that we're doing quite a bit in medicine in general. The surgical space, we're starting to get some solutions deployed. We're starting to see some of the benefits, and we're going to be doing a lot more, focusing largely on real-time analytics in the OR, which I think will be very exciting.
Definitely. Thank you so much, Mohamed, for sharing that with us. Real-time analytics really does sound amazing. And with that, I'd like to pass the ball on to you, Rolando. What can you tell us? What milestones, and there are many, I'm sure, have you achieved in the past? And how is the future going to be looking for you?
Well, first, thank you very much for allowing me to give a little bit of information as to what we're involved with. From my particular area, which is surgical innovation, and particularly the development of the intelligent operating room of the future, what we basically sort of deal with on a global scale is, can we use virtual reality and artificial intelligence to improve the safety of surgery globally? How do we do that? And so what we basically have put together is really a concept of four things. One, we have to develop simulators and other systems that are able to assess individuals' performance, actually able to train individuals, and can they prevent sort of error? Can they develop systems? Can we develop these sort of virtual reality systems that are able to do that? The second thing is, can we validate them? Do they actually work? Do these sort of intelligent sort of systems actually work? The third thing we've been involved with is developing really intelligent tutors. The virtual operative assistant is one, for example, and we've also developed a sort of what we call a intelligent continuous expertise monitoring system. What that system does, it actually monitors performance, surgical performance, literally 50 times a second. It actually can predict error and can predict error well before it occurs. And so that system is available to us. And now what we're basically doing is testing those systems. How do we test those systems? We do randomized controlled trials. That's basically what we're doing from that aspect. And the next thing we're doing at the present time is, can we actually move these virtual reality systems into the operating room and actually move from developing sort of a virtual reality operating room where we develop all these virtual reality systems which can assess, train, and actually prevent error? Can we actually move that into the operating room, into a real operating room? So what do we have to do that? So we're in the process of developing a hybrid operating room where in the neurosurgical world, and instead of, let's say, operating on a human brain, we're operating on a calf brain and really developing a complete model system that we can move into the operating room, the neurosurgical operating room, or any operating rooms of the future to really be able to do such sort of activity. So basically, the world, what we really want to do is have those four things, really. We want to develop systems, virtual reality systems, and other types of systems that are able to really train, assess, and mitigate error. We want to then validate them. We then want to train them to develop intelligent operating systems that are able to tutor students and consultants, for example, to do an operation? And the third part of it, can we really develop the intelligent operating room of this future and really move the intelligent operating room to the smart operating room, which is much, much smarter? And think about what's going to happen, for example, with the movement to self-driving cars. It's basically the sort of same type of system. Can we prevent error by developing systems which monitor the activity of the surgeon? What's fascinating is we can now assess 5,000 things that the surgeon is doing during an operation, develop a complete global assessment of every single thing that surgeon has done during an operative procedure. And then can we pick out the things that are what the expert does by using a huge number of experts, and then with that, those expert surgeons be able to develop what a perfect operation would look like, and then how that perfect operation actually can occur during a real operating room. Really, to prevent error, the major component. Error probably causes $5 to $10 billion of problems in the United States and North America and the world. Surgical error. So the question is, can we bring that down? Can we bring surgical error down and make safe operations throughout the world? And we're using really the airplane model to do that. You know, every pilot that is trained, for example, in the world, in any country can, if trained properly, can actually pilot a 747. So why can't every surgeon in the world use the resources that we have to really make a perfect operation? And that's something that's in the horizon. And I believe the next 3 to 5 years, every operating room is going to be smart. The real question is how intelligent it's going to be, and who controls that system and makes that system better. It's going to improve the quality of care of every single patient that go into the operating room. Simple as that.
Thank you so much, Rolando, for that fantastic overview. And with that, Jan, I would like to pass the ball to you. Interestingly enough, I do have to say that a couple of things that Rolando just mentioned occurred in our pre-talk that we had yesterday, but we might get into that just a little bit later. So now fill us in a little bit more about what makes you and what the future is going to look like.
Well, Kinsley, first of all, thank you so much for the kind introduction. I really appreciate the opportunity to discuss recent AI achievements that are related to the future of surgical care. And as you pointed out, I'm an anesthesiologist, so I must stress that we are not only looking at the actual surgical procedure, that we need to look at the entire perioperative period. Well, as you asked for milestones, for my entire medical career, I have been interested in complication experienced by patients that need to undergo surgery. So we know that roughly in a general surgical population, about 17% of the patients will be affected by some kind of relevant complications, well, be it wound infection, bleeding complications, delirium, acute perioperative renal failure, and there are many, many more. I have always wanted to prevent patients from suffering such complications that often have long-term consequences and that affect quality of life. And one of the differences that we just heard in the previous statement is that these complications are, at least some of them, occur like a few days after surgery, and that's even harder to predict from the data what will happen in the long run. And one point is the underlying mechanisms are so complex and heterogeneous that we do currently not have adequate measures to identify patients at risk. And I believe that the main reason is that until recently, we just did not have the capacity and the methods to store and analyze the huge amount of relevant information. And we could not identify patterns in those data sets that might be relevant for the patients, for the complications. And my personal milestone is that about 3 or 4 years ago, we scored funding for the so-called COMET project, thanks to the Baden-Württemberg Ministry of Research. And we were being able to conduct the COMET project. That's definitely a huge milestone for myself. That's COMET stands for Cognitive Medical Assistant. And what's unique about this project is that we have on one side, we have large-scale clinical routine data like demographics, lab values, imaging data that are collected for those patients. But we also have high-quality outcome data that are prospectively collected by research staff. So every patient in this in the study is being seen by study nurses and doctors that follow guidelines and SOPs for detecting the relevant endpoints. So the data are really high quality. And also the data set is amplified by study-specific data such that are normally not collected in routine data. That are genomic data like whole genome analysis. We have proteomic data for every patient before and after surgery, and high-resolution hemodynamic waveforms from during surgery, and if the patient goes to the ICU, then also on the, from the ICU. So all those data are stored in a medical data integration system, and they are highly structured so that they can be shared, and we can pipe them into a cluster computer environment so that they are available for analysis. And I'm pretty sure that those data will shape the future of surgery.
Thank you very much, Jan, for this overview. And I'll stay with you for this next question, although I'd like to ask you to broaden your perspective just a little bit, or broaden your view, and tell us from your perspective about the current status of surgical process AI research in Baden-Württemberg. What are, in your view, the specific areas of AI in surgical process research in Baden-Württemberg? What can you tell us?
Well, from my point of view, a major focus of AI in the context of surgery is definitely imaging. There are numerous examples from Baden-Württemberg. Researchers at the German Cancer Research Center, for example, work on technologies to identify tumor progress in CT scans, and the goal is to have a higher sensitivity and specificity than a well-trained radiologist can achieve. Also, there's a spin-off company that works on so-called CT biopsies. So they do a 3D scan of the prostata of patients. And the idea is to avoid invasive prostate biopsies for the diagnosis of prostate cancer. They train an algorithm to identify prostate cancer, and specifically, or in particular, to distinguish between benign tumors and malignant ones. Well, you can say similar questions need to be answered by pathologists. Pathologists scan tissue samples with different goals, and one of the goals is to characterize a tumor to identify which treatment would be best for a specific patient. There are also several groups training algorithms to characterize those tumors faster and more efficient than pathologists can do. Also, pathologists work closely with the surgeons and give them more or less real-time or rapid feedback during surgery regarding completeness of tumor removal. So they look at the specimen that is sent for analysis, and they figure out if it has been completely removed, or if the surgeons cut through the tumor and left tumor inside the patient. And that is certainly, that's something you would like to avoid, as it has dramatic consequences for the patients. And now research groups work on multimodal imaging techniques to directly visualize tumor tissue during surgery. So algorithms are trained to take advantage of different characteristics of the tumor, such as vascularization, tumor density, and so on. And all these different applications will make surgery faster and more exact, more efficient, and they will eventually reduce complications and improve outcome.
Thank you very much, Jan. Mohammed, let me ask you, if we look at the operating room of the future, what would you say? What role in general will AI play? And where do you see needs at different levels? Say we look at the medical staff on the one side and then patients on the other side.
Yeah, it's a great question. I think there's going to be several roles, and I'm just going to maybe highlight a few that I think would be exciting. First, I see the role as one of the roles as an information aggregator. There's all sorts of monitors and information and lab values, all sorts of stuff that we kind of have to assimilate in our head. I think the statistics out there involve or include things like the average complex medical decision considers hundreds, if not about 1,000 different parameters. And yet, from the 1950s, if we look at Miller, who's a famous psychologist, famously concluded that the average human can process 7 plus or minus 2 things at the same time. Right? It's not a fair fight. So humans really have a hard time assimilating a lot of information simultaneously and really making decisions on them. Some are better than others, but I feel AI is going to be hugely important in assimilating a lot of information and summarizing for us, this is what it means, and this is the next action item that maybe you want to consider. So that bleeds into the next function of a clinical decision support tool, or an assistant, I guess you could say. So AI could be helping us to identify patients that are high risk for complications. We have several initiatives now that we're just about to launch very soon, actually, where we are able to identify with a very high level of accuracy, actually, which patients are at highest risk for post-op surgical complications. And this information is now affecting our surgeons' decisions to say, maybe I should actually look at medical management a bit more than surgical intervention, or actually we have another imaging project that we're doing actually that will actually help our surgeons decide which procedure would be optimal for this patient. In the OR itself, I think it could actually be an aggregator for information, and a decision support for information. So for example, it will actually be able to tell us 20 minutes in advance when something bad may happen, so that we can actually recourse or do something that's a bit different. We're also seeing surgical assistants in terms of robotic surgery. I know there's a lot of hype out there around semi-autonomous procedures with robots and such. I don't know if we're there yet. I think we will see more and more capabilities of robotic surgery in the future. On the flip side, for patients, I know that a lot of patients get really concerned around, what are my risks? And a lot of times we struggle. There's study after study after study showing how poor we are as clinicians at prognosis. We're not very good. We try, and some experienced surgeons are better than others. But I do believe that we have algorithms. We've actually published a study just recently showing how an AI algorithm is considerably better than clinician judgment alone. So I think we can give patients much more accurate information. There's also a lot of angst or anxiety from patients who may not have all the answers they need in an understandable manner. And understandably, clinicians are very busy. Sometimes there's a bit of a language barrier, or there's a communication barrier. But with the surgence of generative AI through things like ChatGPT, we're able to now summarize information that is accurate, reliable, in a much more understandable manner, and have an environment where patients can actually get their questions answered very quickly and accurately without having to wait or having issues of understanding. We can actually ask generative AI to say, can you summarize this information for me in grade 12 language or in grade 12 comprehension, to make it understandable for people? And the other thing is around not only just simply what happens after my surgery or what do I do, but being able to give patients access to say, based on your information that we're seeing, these are the sorts of things you may want to talk to your physician about. So really getting patients more accessible, understandable healthcare information to empower them to take better care of themselves, but also to have more intelligent conversations with their physicians.
Sounds like a win-win-win situation all around.
I believe so.
Rolando, let's change the view from the patients back to the medical staff. Can you discuss with us the role of intelligent tutoring systems powered by AI in the development of the intelligent operating room of the future?
Well, as being a neurosurgeon for many years and probably having trained over about 100 neurosurgeons that are all over the world, I thought I knew a lot about how to train a neurosurgeon. I was involved in watching the neurosurgeon during the operative procedure. So basically what happens during a normal operation is that the surgeon educator allows that particular sort of student to do more and more based on that particular individual's capability. And therefore, you watch that individual and you train that individual using a verbal way. You tell that individual, maybe you should put your instruments closer together, or maybe you should, be careful about that area. There's bleeding that could occur, et cetera. And if you're concerned about that individual, you'd actually remove that individual from the operating room, from the operating sort of area, and do the procedure yourself. The anesthetists have seen this. Everybody who's in an operating room knows how this sort of system works. And then when we began to look at, let's say, virtual reality operations that were being performed by expert surgeons, one thought that one could ask these expert surgeons, what were the critical parts of the operation? And we got answers. And then when you ran the artificial intelligent algorithms, what you found is the deceleration of instruments, the acceleration of instruments, the way instruments were put together, how close they were, and how quickly they worked together were the clear let's say, conduits of expertise. So one of the things that has happened in sort of surgical education is the idea that we train to competency level. We train sports surgeons to be competent. The question I've always asked myself is, what is competency? How many errors does that mean that a surgeon makes a year? Are different surgeons competent in different ways? And so there's a whole number of things that we have to begin to look at much more carefully, is what is actual competence? And if you use, for example, artificial neural networks, what you find is expert surgeons focus first and foremost on safety. Anytime you do an operative procedure, the expert surgeon initially focuses on safety, and then efficiency and other aspects go after that. So, for example, one of the things that people always look at is how fast the surgeon actually can do a procedure. Well, that's not exactly, for example, the best way of doing that particular procedure, how quickly you can actually do it. What's much more important is how safe you can do that procedure. And when individuals talk about the idea of preoperative care, of course, that's very important. You have to obviously make the proper decision as far as the surgeon is concerned. The intraoperative part of it is obviously important too, but the intraoperative part of it actually determines much of what happens afterwards. It actually determines and when people are talking about how much of the tumor can be removed, that has to do with expertise. How much of the tumor can be removed is an expertise problem. If you have expertise, you remove the tumor. If you do not have expertise, you leave some of the tumor behind. And so all those things rank together related to that aspect. And so one of the questions that you can do is, can you develop systems that can actually train a surgeon the way we train surgeons in the operating room? And actually, can you develop a system which knows how to do that particular operation, has all the data on that surgeon's performance from before, and can determine whether that surgeon is functioning the way they normally do or not? So that's one of the issues that are involved. And if that particular surgeon, we're talking about 5 minutes before 5 minutes before what's going to happen in operation. That's not what happens in operations. What happens in operations is you pick up the error about 1 minute or 5 or 10 seconds before. That's when you pick up the error. The error is going to occur that quickly. How quickly the error is actually going to occur. It's not 5 minutes before, it's a few seconds before you're picking up what's happening. That's going to cause that aneurysm to burst, or going to cause that instrument to go through an important structure. So those are the things that are happening now. We're really understanding what actually happens during an operative procedure. What actually happens during that. So if you can determine what's happening to instruments that are moving in 3 dimensions 50 times every second, you can determine a lot of what's going to happen during that particular procedure. So we have to begin to think, what actually are the composites of expertise? Can we train those composites? Can we use artificial intelligence tutors, virtual operative assist, and other systems to make the surgeon better? The second thing is, how do we mix the expertise that the expert has, who's trained operative procedures for multiple years, and the artificial intelligence system? How do we fuse those two to get the best possible outcome? The human input and also the expertise input from these artificial intelligence tutors. Can the artificial intelligence tutor help the surgeon educator make that operation much more safe? How do we do that? And how do we test that? How do we do randomized controlled trials to really see if this really works? And learn more information about what actually happens during real operative procedures. Because one of the things that we don't know at the present time is what actually does happen during an error during an operative procedure. Is it because the surgeon has used too much acceleration of an instrument, has made too much force with that particular instrument, has not put those two instruments together the way they should, has let bleeding occur just a little bit too long, where the machine would actually say, bang, 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 bang. You're letting too much bleeding occur. You've got to stop it. So those are the types of things that we can begin to look at very, very scientifically for the very first time. I didn't know and I'll just repeat this, I didn't know that how you decelerate an instrument is critical to how you do a particular operative procedure. And if some other surgeon knew that before me, more power to them, but I did not know that. And it is critical. The acceleration of an instrument, the force you're using on an instrument is absolutely critical to expertise. And expert surgeons have learned that. And now what we have to do is use that information, put it into the machine, and have the machine help the non-expert surgeon become as close to expert as possible. The other thing I just want to mention, just one thing. Why do we accept competency as a surgical outcome? We have individuals who are Olympic trainers in our labs. They find it incredible that in the surgical world we accept competency rather than expertise. No Olympic trainer accepts competency. They want expert, and that's what surgery should be, an approach to make everybody who is involved in surgery as expert as they possibly can be to continue to improve surgical care for all our patients. That's it. How do we make these individual experts and continue to keep them as experts throughout their whole career?
And a virtual environment seems like a perfect safe space to train exactly that. I'd like to change the perspectives just one more time. You had mentioned if the surgeon has an error in speed and velocity in the movement of the tools, items used, that great danger can occur. If we switch the perspective once again to the patient itself and the risk factors that the patient brings. Jan, let's go back to COMED for 1 second. What do you think about the role of AI in the operating room of the future, and what is your experience already today with COMED in this regard?
Well, I think that one area where we will likely see a lot of progress in the recent future, and I mean translation into clinical practice is already happening, that's augmented reality. So what that somehow relates to what we just heard. It's I think a good example is fusion imaging, where anatomical information that are derived from a preoperative 3D imaging technology, or such as CT or MRI, can be projected into a surgeon's visual field. And this way we can visualize important structures during surgery that are not easily apparent to the operating surgeon. That might be blood vessels, which cannot always easily be identified during surgery. Also, it could be nerves, for example. And these techniques are not only helpful for surgeons, but also for cardiologists or vascular surgeons, for anesthesiologists, or people that need vascular access, for example. We need to maintain vascular access via the skin, and we cannot see through the skin. And we use ultrasound, but ultrasound can also be superimposed with anatomical structures from 3D CT scans, for example. And then we all heard of Apple's Vision Pro last week, and I believe that mixed reality will also have to draw attention where it's actually needed. Like in hemodynamic monitoring, there are so many different variables that need to be taken into account, in particular for beginners in anesthesiology or perioperative medicine. It's not easy to identify which parameters are really relevant at a given moment. And I believe that this is something where AI can be really helpful, and that can also be operator specific, so that there are different roles defined and different people, like the surgeon, need other hemodynamic information than the anesthesiologist, and then the consultant might need other information from different patients at the same time, where while our anesthesiologists that are in a operating room need the full picture. And I believe that mixed reality or augmented reality is one of the areas that where we see like really progress in the very near future.
Thank you very much. Now, just a brief look at the time. We're going to get to the questions from our audience members in just a few minutes, but I have some more questions for our esteemed panel, but I'm going to have to ask you for these next questions to have short answers, please. Otherwise, I'm not going to get through with most of them. So, Mohammed, let me get back to you. Where do you think, and in your perspective, where is AI already being used in Ontario and your regions, and and which technologies do you believe have the potential to become popular?
Thanks. It's a great question. There is a bit of activity in Ontario around using AI in healthcare in general. Again, our hospital has close to 50 of these solutions up and running and live, helping our clinicians and helping us make decisions. There is quite a bit of investment that's needed to actually make sure that these processes work well. But there are other centers too. So, for example, there's quite a few actually using commercial products that are available to look at, for example, in stroke with image detection around brain bleeds and such. So there are commercially available algorithms for that hospitals are using. But Princess Margaret, for example, has developed and is using a treatment radiation plan algorithm that actually develops radiation plans. These typically take hours, if not days, with multidisciplinary teams, whereas it can develop a treatment plan within minutes. And I think the agreement between the algorithm and clinicians is about 88%, so it's fairly high. And that's being used at the hospital. I think what we're seeing in terms of other applications, it's hard to go from research to deployment. So you'll see a lot of research in the space. But at our hospital, we have, again, as I'd mentioned, we have algorithms that go from efficiency gains, reducing human effort, to improving clinical outcomes, to all sorts of other things like, for example, summarizing notes. We have an algorithm that will look for our patients with chronic disease, for example, in multiple sclerosis. These patients have chronic conditions. I'll give you an example. A patient has 7 years of history. It's really hard for a clinician, especially our fellows and our residents, our junior doctors, to say, all right, I just finished seeing a patient. In 10 minutes, I'm seeing another patient with 7 years of history. How am I going to remember everything? So we have a program called Muskrat, where it takes actually less than 2 seconds. It summarizes the 7-year history in a visual. And it says, this patient had a relapse here and here, and here and here. They had new T2 lesions on their MRI here and here. You tried this drug 4 years ago, you switched them to this, now they're on these medications, and their EDSS or disability score is this, and it changed to this, and in 2 years, we're predicting they may end up in a wheelchair. So if you're interested, you could actually say, I wonder what happened here with this T2 lesion. It'll pull up the entire radiology report for you. So it summarizes everything in a very nice visual format, so people can actually have good information right at the time of patient care, so they're not flipping through notes really quickly trying to find out where this information is. So those are the examples of things that we're already doing, and we're excited about how we can extend some of this to the surgical population. That's what we're going to be spending a bit more time in the next few years.
Thanks for sharing that with us. Rolando, what would you say are the outstanding strengths, and I'm sure there are many, of Montreal and the region of Quebec, and what sets it apart when it comes to the application of AI in surgical care?
Well, as I mentioned to you, I mean, one of the things that's important is the development of machines, the virtual reality machines, the augmented reality sort of systems, etc. Back to the augmented reality, Jan, for your experience, you mentioned this. As a surgeon, I started working with this about 15 years ago, the augmented reality. During my role was as a tumor surgeon. That's basically what I've done all my life. And we would project the tumor onto the brain surface. And as soon as the brain would move, the brain is a viscoelastic thing. It moves immediately. So when you just start removing the tumor, the augmented reality systems just don't work anymore. They're not able to keep up with what actually is going on second to second related to the operation. So I basically thought that particular system is not going to be that effective because of the thing that's happening all the time related to almost any type of operating procedure as far as the brain is concerned. Now, if you have a tumor that's stable, that is not moving, then clearly it's important to use augmented reality. But again, you don't have a continuous feed as to how it changes second to second related to what's happening. So those are things that may have to be developed in the future to make it more realistic to what's really going on related to an operative procedure. So it's not that I didn't think that augmented reality was important. When I used it, I just didn't feel it helped me a great deal. That was my problem when I was starting to use it. So we'll see what happens in the future. I think a mixture of augmented reality, virtual reality, and some of these other systems all working together may be a way that it works maybe a little bit better on that in that world. Now, as far as Quebec is concerned, I think the advantages we have in Quebec, we have a National Research Council that is based in Montreal, for example, and its expertise is in virtual reality. For example, every automobile that has a gas tank, that particular system is developed in the National Research Council. And so there's all kinds of virtual reality systems that the National Research Council has been involved. That's one of their areas of expertise. The second thing is we have CAE, which is the largest simulator company in the world. It simulates all, every plane that is up in the air has been simulated through that particular company, and it's also based in Montreal and has a very, very large healthcare system. Again, has many of these, has developed many of these systems, for example, angiography and all kinds of other types of systems related to augmented reality, et cetera, associated with healthcare. So that's another big strength that we have. And the other strength we have is the gaming industry, which provides us with large numbers of individuals who have a lot of expertise involving 3D and 3D dimensional types of areas, which again can be very useful from those areas. And of course, all the robotic people that are involved in all these areas. So those tend to be the expertise. And the second thing is you really do have to have expertise in trials, doing randomized controlled trials, doing crossover trials, doing the trials that can determine what types of systems actually work. So you have to have those expertise systems along with it. And I think the other thing we have is we have expertise associated with the Olympians. We have Olympic coaches that we have access to related to the Olympic training centers. And again, they have helped us a great deal develop sort of ways of thinking about things. For example, you can train, how does it, every Olympian is being trained using EEG and using all kinds of other systems which improve their actual performance. And can we use those types of systems also? For example, we've looked at virtual reality operations in which the patient actually has had severe bleeding and is going to die, and assess what happens to the EEG of the surgeon during that particular procedure. And what we've learned is expert surgeons go into a particular EEG pattern, which is exactly the same as an Olympian's pattern. It's a focused pattern that they can use they remove stimuli from their environment and focus all their ability on what's happening in front of them. And it's a particular EEG pattern that we know about, and the Olympians know a lot about it and how to train that particular pattern. So can we train those types of patterns with our own surgeons? Can we use this huge amount of information the Olympic coaches have to train surgeons to be even better at what they do, and to use all kinds of information related to that, everything from your stress level we know how to assess stress during operations. We have all that ability, and we can continually do that. And so again, those are the expertise that you need. You have to be able to build systems, have to be able to validate them. You have to be able to put them in place and develop systems and then test and see if they really work.
I think we could all benefit from being in those specific EEG zones, being in an operation or in an Olympic trial or just being in everyday life. Now, I'd like to open up the panel for a question from our audience members. This question is from Maria Tamaya, and it's directed at all of you. What are, in your opinion, the biggest barriers to be faced to implement the AI solutions you are talking about? So briefly, just name 1, 2, or 3 barriers that you are facing every day. Jan, I'll start with you.
Well, if I look at barriers, I would say in some cases it's the availability of data that has been gotten better over the past years, but still we do not have enough data to train all the algorithms and answer all the questions we would like to. And in particular, I think one of the challenges is to use an algorithm that has been trained somewhere else on your own patients, because our patients are different from patients in Canada or in the UK. They come in different disease states. The physicians are different. The entire healthcare system is different. And I believe that's a major obstacle if we look at the future of AI.
Mohammed, what barriers are you facing?
I think from our perspective, it's less about data because data's there. More about machine learning operations. It's the until the companies figure it out, because there is a process around how you get data from systems that already exist, the data governance that allows you to be able to get all that data, but also to be able to process it in real time in a manner that can feed AI algorithms to then actually take the output and feed it back into the clinical decision-making process. So this thing called ML ops, or machine learning operations, is something that I think we need to get better at. But I think the other second thing that's very big, I think, from my perspective, is trust. Understanding that algorithms are not perfect, they're going to make mistakes, but understanding also that some algorithms, and being able to determine which algorithms are actually not as good as clinicians, so there's no point in deploying them, but algorithms that are just as good, if not better than clinicians, but how do we trust them? Because if you have an incredible algorithm that our clinicians don't trust, it's not going to be used. But if you have a not so good algorithm, but for whatever reason our clinicians trust it, it'll probably be used.
Rolando, before I get to you, Jan, let me just circle back to you. I had to notice there was a slight smirk on your face when Mohammed said, well, the data is there. So what's your stance on that? Is the data not there where you are?
Yeah, it probably depends on the institution, and it might also be like, I think that our data protection laws might make it sometimes at least more difficult to get to the data that we need in time. And I know that this is different in other countries or other healthcare systems.
Thank you, Rolando, for clarifying that. And it's something we spoke about in our pre-talk, of course, also. Rolando, tell us, what are the barriers you're facing?
The barrier we're facing is we don't know how operations are done in the operating room. We don't have the real data. So until we get real data from how an operation is actually done in an operating room, we actually get the acceleration of instruments, the deceleration of instruments, all that type of data in 3 dimensions. It's going to be a little bit difficult. So we have to move the virtual reality system where we can get 5,000 bits of data on every single operative procedure continuously. In the operating room, related to instruments and things, we have very little data. And so that really is the I think the major thing that has to be a challenge. We have to develop an intelligent operating room. And at the present time, although we have blood pressure, although we have let's say respiratory rate, we have temperature, we have other aspects, we don't really have a lot of information on how the operation is actually going inside the actual patient. And so that information in some way has to be available. Now, clearly we can do videos, and videos are going to be one of the big areas that are going to expand in the future. The problem with videos is 3 dimensions. The operations occur in 3 dimensions. They do not occur in a flat screen. And therefore, there's going to be problems associated with force. There's going to be problems associated with bleeding and things that we're going to have to deal with. And somehow we have to get the same types of information that we get in a virtual reality world in the operating room, or at least something closer to it, and then be able to sort of use that information in the background continuously to help the surgeon and to help the surgeon educator. That, I think, is going to be the other one. The other thing is, I agree, with Mohammed. One of the problems we've always had is getting an older surgeon to do a virtual reality operation. And one of the clear things that happens as you age is you develop a bigger tremor. Mm-hmm. There's no question, the tremor gets worse. Mm-hmm. And it's easy to identify. It's not a problem at all. It's not a problem that various other sort of technical things start to degrade. And, we're going to have to deal with that as a society in some way. And I don't think our society is ready for this yet. That people who age have a change in their technical ability. And we'll have to deal with that at some part as a society and how we're going to deal with this. At the present time, we do not test, like, for example, every pilot who's piloting a major airplane is put into a simulator twice a year. And if they fail the simulator, they're retrained for 6 months. If they fail it twice, they never pilot a commercial airline again. This is what's happened in the airplane industry, and it's sort of a model. And I'm not sure the society is ready for this as far as surgery or medicine is concerned. We're going to have to see how we deal with that as a society.
Thank you very much, Rolando, for your insights. Definitely a lot of food for thought from you, as well as my other two panelists. I would like to thank Dr. Jan Lahmann and Dr. Mohamed Mamdani for joining us today, for sharing their insights, for sharing their knowledge, for taking time out of their busy, busy schedules. As I could see with you, Jan, yesterday, you were practically in the middle of several operations while we had our little pre-talk. So I do appreciate it very much that you all took the time. We will see you, Rolando, in just a little bit in the second part of our 2 power sessions, where we'll talk about fusing AI and virtual reality to improve surgical performance. So, dear panelists, thank you so much.